Okay, great. So it's my pleasure to introduce the next speaker. He's a colleague and friend of not just the foundation, but of course the Prion Center, and that's Dr. Ryan Maddox. He's an epidemiologist at the CDC at the Prion Public Health Office. Always have a great relationship with Ryan. You know, we are kind of on the sidelines watching CDC struggle with COVID, and you know, of course, they were very highly involved in that, and somehow they're able to very effectively juggle not everything that they had to do with COVID, but also Prion, and we really took a lot of inspiration from that. So he's going to give us an overview of CDC activities for the surveillance of Prion disease. So Ryan, thank you.
Thank you, Brian. Thank you to the organizers. It is indeed great to be back here in person with all of you, and see if I can figure out how to work this gizmo. I can, great. Yes, so as Brian said, I do work for the Centers for Disease Control and Prevention. We're based in Atlanta. Some of you may have seen me wearing a mask around. I don't have any insider information. I did get a few questions. Just have an immunocompromised person in my household, so we're a little extra cautious. So don't worry about that. Basically, CDC is under the Department of Health and Human Services. We're the nation's leading public health agency. Our main tasks are to control disease outbreaks, make sure the food and water are safe, to help people avoid leading causes of death, and to reduce threats to the nation's health. And that includes a global outlook as well, because as you've certainly heard, what happens in other places can certainly affect America as well. We are headquartered in Atlanta. We have facilities in 10 additional U.S. locations. We have field staff in all the states, more than 50 countries, more than 14,000 employees. So it's a very large operation. Within that organization, we are in the National Center for Emerging and Zoonotic Infectious Diseases. Our particular division is the Division of High Consequence Pathogens and Pathology. And within that, in the very small corner, we are the Prion and Public Health Office. There aren't very many of us. In fact, a large percentage of our office are here in this room. That would be Larry Schoenberger and Joe Abrams. You've probably seen them around as well. There are a few more of us back in Atlanta also. But basically what we're tasked with in the Prion and Public Health Office is surveillance for human prion diseases. What does that mean? That means monitoring of the disease in the population, including things like estimating prion disease rates, looking for changes in the epidemiology of the disease over time, monitoring the possible occurrence of variant CJD or other new prion diseases, and just gaining knowledge about these diseases. So how do we do surveillance? Our main source of surveillance information is death certificate data. As you're all very much aware, these diseases are always fatal. So death certificates can be a very cost-effective source of information about prion disease deaths in this country. We obtain that death certificate data from the National Center for Health Statistics, which is also part of CDC. But death certificates are not perfect. So what we do is we use our collaboration with the National Prion Disease Pathology Surveillance Center and look at their results from their specimen testing. And we match that data to the death certificate data. And by doing this, we can cross out the cases that had negative test results from the Prion Center. We can also add cases that were positive at the Prion Center but did not show up in the death certificate data. So it's kind of a labor-intensive process. Someone smarter than me will hopefully find out a better way to do it at some point. But we go through and we match the data to the best of our ability. I spoke with some of you yesterday concerned about death certificate misspellings or what actually ends up on the death certificate. Fortunately, we do account for that to the best of our ability. For example, any number of misspellings of Creutzfeldt-Jakob would be picked up through the system that we have, as well as any number of different ways they could call these diseases. Prion disease, mad cow even ends up on death certificates. We do become aware of these death certificate cases as well. From the period 2003 to 2020, there were 7,921 decedents who were identified with prion disease. That comes out to about 1.2 cases per million population, a little bit higher among males, 1.1 for females. When you look at the older age group, as you're aware, this primarily affects the older population. Those greater than or equal to 65 years of age, it actually goes up to 6.1 cases per million, so a little bit more. But another statistic you heard yesterday was that 1 per 6,000 or 1 per 5,000, meaning when we look at all the deaths in the country in 2020, 1 out of every roughly 5 or 6,000 were diagnosed with the prion disease. And the reason I keep mentioning 2020, that is our most recent year of complete data. We're in the process of reviewing 2021 data right now. Preliminary data suggests that it's very similar to 2020 and to 2019, which is a good sign. In 2020, we had 568 cases, 571 in 2019. That comes out to 1.3 per million. We found definite or highly probable matches of 87% of cases in the death certificate data when we were doing this matching process with the Prion Center. And that really speaks to the Prion Center's expertise in increasing awareness of their services, that so many cases of prion disease have passed through that center and had specimens tested there. To give you an idea about our matching process and what that yields, 10 cases had autopsy that were negative at the Prion Center, but still had a death certificate diagnosis, and so they were removed in 2020. There were 40 cases autopsy confirmed at the center that were not found in the death certificate data, and those, of course, were added. So I know there's always a lot of concerns for people where CJD or prion disease did not end up on the death certificate. If they were processed through the Prion Center, we are aware of those cases. This graph just shows the increase of cases during the time period 2003 to 2020. It's not as concerning as it may look to some of you. You do see an increasing trend when you look at the bars there, but I think there's two main factors that can account for this. One, of course, again, this is a disease of the older population. There is an aging population in the United States, meaning each year there are more old people. The boomer generation is getting to that age group, and so because CJD affects the older population, we're simply going to see more cases. There's no real way around that. But also the increasing diagnostic improvements we've seen in recent years, the RT-QuIC I mentioned, MRI, these things are picking up more cases. There's more awareness among providers. Fortunately, a theme of this conference every year is there's still a long way to go, and I certainly have heard that complaint, but we are still trying to get the word out about these diseases. So I mentioned RT-QuIC. As you're all aware, this does strongly indicate prion disease when positive. If the Prion Center, though, does not conduct an autopsy on an RT-QuIC positive case, they may not have the date of death for that patient. That makes it hard for us to match those cases to our death certificate data. So we took a look at 2020, and based on some estimates, we think we may have not accounted for almost 20% of cases that had an RT-QuIC positive, but from what we could tell, did not show up in the death certificate data. But again, we didn't have that date of death. And so the next step is we're going to try to compare those cases with the information we do have to the National Death Index, get that date of death, integrate those cases into our data so we can get an even better number of our annual number of cases. And our prediction is that's going to increase that 1.2, 1.3 to 1.5, 1.6. And if you've looked at our website recently, we do say 1 to 2 per million per year with this disease. So 1 per million is a little outdated. It's still a nice thing to say just to kind of give an overall feel for what's going on. But in reality, if we saw 2 per million, we wouldn't be overly surprised. 10, 20 per million, we would be very surprised. But I don't think even including these RT-QuIC cases, we're going to reach anything like that level. We also focus on young cases of disease. These cases can truly be a signal for something unusual going on. Most of these young cases, less than 30 years of age, have a genetic mutation or other risk factors such as human growth hormone. The initial variant CJD cases had a median age of death of 28. So a lot of time, these are the cases that could be a signal for something of increased concern. And they're extremely rare. Only 18 young cases that we're aware of from 2003 to 2020. That comes out to 8 cases per billion per year. And only 6 of those were sporadic, 3 being sporadic CJD and 3 being sporadic fatal insomnia. So a sporadic case, less than 30, certainly is a rare event. The remaining 12 cases were familial. We did have 2 variant cases and 1 iatrogenic case that was related to dura mater. Those 2 variant cases I'll touch on in a minute. There's usually only 1 at most of these young cases each year. 2019 was a little unusual in that we had 3. We were back to 1 in 2020, and looking at 2021 data, we're only aware of 1 case with a 0 in 2022 that we're aware of at this point. These diseases still can only be confirmed by neuropathology. As great as that RT-QuIC test is, we're still comparing it to the autopsy as the gold standard. So we encourage autopsy still. There's a wealth of information that can still be gained by brain tissue analysis that the RT-QuIC does not provide. And the neuropathology can be a sentinel for those unique and possibly emerging prion disease cases that might have strange neuropathological findings that alert us to something unusual going on. I mentioned, of course, the death certificate data and the Prion Center data. We also may find out about a CJD case through public health departments, medical personnel, but also family members, the public, and the media. The cause of death on death certificates can be amended. I know that's something that comes up in this group quite often, but the process does vary from state to state. That's not a CDC issue. It's something that unfortunately the family often has to struggle with and take on with the state authorities to have that process completed. But again, even if that death certificate is not amended, if there was a prion disease testing component, we are aware of those cases, and we do include them in our national prion disease surveillance. But my disclaimer that I say every year, we do not capture every single CJD case. Simply can't be done, but we do try to get as many as possible based on the mechanisms that we have at hand. We do work very closely with the states. We provide additional funding for a handful of states to do enhanced surveillance, but every state in here in the country is aware of the Prion Disease Center and works closely with them. State reporting requirements vary, but it is reportable, CJD, in most states to some degree. The bottom line is a misdiagnosed case will still be a misdiagnosed case. So if they're calling it Alzheimer's, it's not going to be reported to the authorities as prion disease. We did work with the Council of State and Territorial Epidemiologists years ago to write a position statement outlining CJD surveillance actions and goals that we think would be appropriate for states to try to follow. And making the disease reportable in a state may help those states accomplish those goals. So we do encourage the states to take actions that can enhance their surveillance activities. And like I said, we do provide funding to strategic states for enhanced surveillance. Several clusters have been reported to us in the past year, actually, and from time to time in previous years as well. And the bottom line is when we look into these clusters, what we find is that they are not actual clusters due to various reasons, including sometimes they're not even prion disease. You know, initially the doctor, the neurologist may think he has 3 cases of CJD in the same year in the same hospital, but it turns out upon closer inspection that one of those cases was a different neurological disease. One of those cases actually lived 3 states over and happened to be diagnosed in that hospital. There may be genetic forms of prion disease in a cluster that somewhat diminish the impact of that cluster if it was due to a genetic mutation. And sometimes 3 cases in an area is not outside what we'd expect statistically, because a hospital may serve 3 states, depending on where it's positioned, and that denominator is so large that you'd expect a certain number of cases in any given time period. So we work very closely with our state and local health departments as valuable partners in these investigations. They're usually the ones that are on the ground working with the hospitals and trying to look at the medical records and make sure those diagnoses are correct. We certainly don't want to draw alarm to these situations when in fact usually we don't find anything that seems statistically anomalous. A little bit about variant CJD, just to make the distinction between that and classic CJD. Variant CJD is the human form of a bovine spongiform encephalopathy. Only 233 cases worldwide, most of those in the UK, 4 in the US, 2 in Canada, but none of those have been believed to be exposed to the infectious agent in North America. Interestingly, variant CJD, 3 of the 4 cases reported since 2016 have been attributed to occupational exposure rather than consumption of contaminated beef. Now, we can't say that beyond, anything. There's still a chance that there could have been a different exposure, but the evidence seems to suggest that these cases happened in a lab setting where people were working with certain agents that caused the disease. The FDA guidance for industry suggests that human cells, tissue, things like cornea, skin, bone, heart valves, if you have variant or other forms of CJD, you would not be eligible to donate. If you have history of CJD in a blood relative, same situation. Or if you spend a certain amount of time in the UK or Europe during a certain time period, you would not be eligible to donate. However, there aren't regulations from the FDA for organ donation, such as liver or kidney. There's no absolute exclusions. Organs can be donated if you had CJD, but they may or may not be used depending on the outcome of a risk-benefit analysis by the medical staff. New recommendations came out about this time last year, and I believe Lauren Crowder will be speaking about the Red Cross blood program a little bit later this morning. But briefly, the updated guidance removes the donor deferral criteria for BSE exposure, meaning if you were previously deferred for time spent in the UK, France, and Ireland, or receiving a blood transfusion in those areas, you may now be eligible if you meet other eligibility requirements. And this was a huge deal. We were contacted for years from people that spent time overseas that really wanted to donate and were being deferred. And now they are able to donate blood. People that are diagnosed with the Prion disease are still deferred. People who received a cadaveric HGH, human growth hormone treatment, or dura mater transplant are still deferred. So there are still some deferral criteria, but it has opened up a lot that will allow more people to donate. And again, that was based on an assessment of the risk involved. And what is that risk? Well, CJD itself has not been shown to be transmissible through blood. Again, we'll hear a presentation from the Red Cross later this morning, but there have been studies that have shown no evidence of CJD transfusion transmission. I have some quotes there from the Red Cross and CDC and the UK National CJD Research and Surveillance Unit, basically saying if this does happen, if CJD is transmitted by blood transfusion, it must be extremely rare if it happens at all. Now, that's different from variant CJD, which has been shown to be transmitted through blood. It's been reported in a handful of UK recipients of blood, interestingly collected up to 3 years before VCJD onset in the donors. And because many UK residents have potentially been exposed to BSE, there are still concerns about additional secondary spread of the agent through blood and possibly contaminated surgical instruments. However, as I pointed out, we haven't seen many variant CJD cases in recent years. The ones we've seen probably are due to occupational exposure, so that risk seems to be losing steam, which is great. And as I said, the deferral criteria has been adjusted in this country accordingly. As far as funeral homes go, another issue I know a lot of you run into, embalming bodies of CJD patients who have an autopsy can be safely performed, but a funeral home cannot be forced to accept a body. We can't make them do this. It comes down to education, but some people are going to be more open to adjusting their policies than others. We do have information on our website about appropriate funeral and crematory practices, including the quote that there aren't special interment, entombment, inurement, or cremation requirements for patients with CJD due to the perceived low risk or zero risk of environmental contamination and the fact that cremated remains can be considered sterile. I'd like to touch on chronic wasting disease briefly. This is an increased concern that we have. A lot of our surveillance is focused on this disease of white-tailed deer, mule deer, elk, moose, and reindeer. Why is that? I'll get into that in a minute. Basically, clinical symptoms in deer include weight loss, behavioral changes, difficulty swallowing. It can be highly transmissible within cervid populations. In the last month alone, we've seen 2 new states added to our list, Oklahoma and Florida, bringing it up to 31 states that have found the disease in the wild, 3 Canadian provinces, and also found in Norway, Finland, and Sweden within the last 10 years. So it's not just a North American problem anymore. I show this map every year. Every year we have more areas of red, which are showing counties where it's been identified in free-ranging cervids. The 2 circled areas, of course, are Florida and Oklahoma, where it's been most recently found. And next year at this time, you'll see it further because this is, again, highly transmissible in deer populations. It does appear to be spreading. There's no strong epidemiological evidence for the occurrence of this disease in people. That's the good news. But as that map showed, we're finding this disease in more and more areas, which means increased opportunities for human exposure. We have the history of bovine spongiform encephalopathy transmitting to humans. So there is precedent for animal prion diseases to jump that species barrier and cause human disease. There's actually animal studies suggesting the potential for CWD transmission to humans as well. There's contradictory results out there, but there are some that have shown that potential. And finally, there's multiple CWD strains that may have different transmission properties. So all these things suggest continued vigilance is essential when it comes to chronic wasting disease. And so, like I said, we've put a lot of focus on this problem, and we have several studies going on to determine whether this disease can cause disease in humans. And one of those is following up people who hunted in Wyoming and Colorado where this disease has been present for years. It was actually first identified in that area decades ago. And we're looking at those people that purchased hunting licenses there and identifying who died of prion disease. And the good news is so far, the number of identified human prion disease cases in those 2 states has been within the expected range. We also look at people in Wisconsin who consumed venison from CWD-positive deer. The state health department reaches out to hunters with their test results, and if that test result was positive for the deer that they harvested, they ask the person, did you consume any of the deer? And if they say yes, they write their name down, and we have maintained that list. We compare it to the mortality data. We compare it to data from the Prion Center. We have not found any prion disease cases in anybody in that list so far. We certainly hope that continues, but this is really a direct line between exposure and hopefully not disease that we can look at. So we continue to do that. These are long-term studies based on what's likely a long incubation period if it exists. So we have to continue these studies into the future to really get a good answer. And we analyze highly CWD endemic states compared to non-CWD states to look for any differences that might be occurring. Finally, I'm going to touch on COVID real quick. This is, again, a hot topic that comes up because there's an assumption by some that there may be a relation between COVID, the COVID vaccine, and prion disease. The problem is, again, I'll say it, this is a disease, CJD, of the older population, and you look at that group in particular, almost everyone in that age group has received a COVID vaccine. So you are going to expect some of those people to come down with CJD, sometimes in close proximity to when they received a vaccine shot. So the fact that that's happening is not unexpected, just based on chance alone. We also typically look at long incubation periods with prion disease, like I just mentioned with CWD. So if someone gets the shot and starts having prion disease symptoms a week later, the odds that these two things are related are extremely low based on our knowledge of these diseases. I mentioned that 2021 and 2022 and 2019 and 2020 all look pretty similar in terms of our numbers of prion disease cases. So if COVID was truly causing prion disease and incubation period not being a factor, we'd certainly be expecting a blip at least, or something like more cases in the younger population, or something unusual, some sort of signal. The last bullet there, you can see the Prion Disease Center has not seen unusual neuropathological features in anyone that's been reported as a possibly vaccine-related prion disease case. So nothing is pointing towards a connection, and hopefully that will certainly continue. Final thoughts, these diseases certainly present unique diagnostic and public health challenges. Our activities include conducting surveillance through various methods to best capture the majority of cases. We investigate cases of interest in collaboration with our partners, including the affected states, and we try to provide the best advice on prion disease-related issues, including infection control and things of that nature. Collaboration, of course, is essential with not only medical and public health personnel, but with the Prion Center and the CJD Foundation. And finally, improvements in the premortem diagnostic testing, like RT-QuIC, should really benefit surveillance efforts. Autopsy remains important, though, and additional information, like date of death, is needed from a subset of RT-QuIC positive cases to really make our surveillance even stronger. Of course, you're aware of these resources, and I'd like to, of course, acknowledge the people I work with, as well as the agencies listed there. Dr. Armis Boulay has actually moved on to a different center within CDC, but he remains interested in our activities, and we meet with him regularly just for consultation. So he hasn't completely left us. And again, the CJD Foundation, the Prion Center, and our state and local partners are all very valuable in our efforts. Happy to answer any questions.